Hello, my lovely friends. I am Dr. Arun Swami, coming with most expected MCQs from the physiology for upcoming FMGE examination. Guys, in this exam, if you will avoid the silly mistakes, you will slightly increase your marks. So, whenever you are reading any MCQs, just take a 2-3 second pause at that MCQs and then think about it and then please try to answer. अगर आप लोगों ने बेटा ऐसा कर लिया कि थोड़ा सा पॉज लिया, सोचा और फिर उसको आंसर कर दिया, तो बेटा डेफिनेटली यू विल अवॉइड अ लॉट ऑफ सिली मिस्टेक्स विच नॉर्मली यू डू. और अगर सिली मिस्टेक्स आपने कम कर दी, डेफिनेटली योर मार्क्स विल बी increase significantly, right? So let's start this most expected MCQ part. The first question is, a newborn present with persistent hypoglycemia due to excessive insulin secretion. Which glucose transporter normally acts as the glucose sensor in pancreatic beta cell? Option A is GLUT1, GLUT2, GLUT3 and GLUT4. Please pay attention. Whenever you will see all of these MCQs from the GLUT part, guys, normally you think about the GLUT4. But the catch in this MCQ is that this is not asking that which transporter is present into the adipose tissue, skeletal muscle or the cardiac tissues. Guys, this is asking that which transporter is actually present into the pancreatic beta cell, and in pancreatic beta cell this is GLUT2. This is GLUT2. So please see this table before the exam. GLUT1, GLUT2, GLUT3, GLUT4 and the GLUT5. Guys, this GLUT5, this is actually for the fructose. This is for the fructose. This is for fructose and this is again situated in intestine. This is situated in intestine, right? So you can remember 5 F for 5 F for fructose. Now please pay attention. Out of this all the glutes, only the GLUT4, this is actually the insulin dependent. This is insulin dependent. Insulin dependent. Rest all are insulin independent. So this is the catch which you have to be remember, that this is insulin dependent GLUT4 and rest all are insulin independent, means they do not require the insulin for their functioning. So please pay attention. GLUT1 is present into the blood-brain barrier and in heart. GLUT2, that is in liver, pancreatic beta cell and the small intestine. This small intestine part, please pay attention. This is at basal side, or you can say this is at the contralateral side, right? And then GLUT3, this is in brain, neurons and sperm, and GLUT4 in skeletal muscle, adipose tissue and the heart. So in the MCQ they ask about which GLUT is present into the pancreatic beta cell. This is GLUT2, right? GLUT2. Also remember about SGLT. Please pay attention. The SGLT with 1, this is situated in apical wall of intestine, and SGLT2, it is present into the PCT of renal tubule. They both are secondary active type of transport. And this GLUT is, all GLUT are facilitated type of transport, right? So please remember this fact, that GLUT is facilitated type of transport and SGLT, it is the secondary active transport, right? So the right answer of this question is GLUT2, right? Option B. Coming to the next MCQ. A researcher blocks the ryanodine receptor in skeletal muscle. What is the immediate consequences? Increased acetylcholine release, failure of calcium release from the sarcoplasmic reticulum, increased sodium influx and increased ATP production. Guys, this is a very important topic. So you have to remember all of this mechanism of this ryanodine receptor, DHPR, dihydropyridine receptor, and how this calcium is actually gets out from the sarcoplasmic endoplasmic reticulum. So the right answer of this question is the failure of calcium release from the sarcoplasmic reticulum, because this is asking about the ryanodine receptor. Ryanodine receptor. And guys, please pay attention. This ryanodine receptor is actually responsible. This ryanodine receptor is actually responsible for calcium release from the sarcoplasmic reticulum, right? So you remember when the action potential comes, जब ये आता था बेटा तो ये T tubules में जाता था और T tubules में there is actually the DHPR receptor. This DHPR opens up due to this calcium, and guys, then this DHPR mechanically opens the ryanodine receptor. Ryanodine was the gate for this sarcoplasmic endoplasmic reticulum, and inside of this sarcoplasmic endoplasmic reticulum there is deposition of the calcium. So it was a calcium bank, and guys, whenever this calcium want to get out, guys, ryanodine receptor need to be open. So if ryanodine receptor is not opening, what will be happening? This calcium can't be get out from this area, and it can't go into the sarcomere area. And guys, if no calcium in sarcomere, it won't bind with the troponin, and if no troponin C binding is there, tropomyosin will not get away from the actin, and actin myosin coupling could not be happen at any point of time. So muscle contraction could not be happen. तो ये बात अपन ने क्लास में भी करी थी कि मसल कॉन्ट्रैक्शन को चाहिए कैल्शियम, और अगर कैल्शियम चाहिए तो कैल्शियम कहां से आएगा? सार्कोप्लाज्मिक रेटिकुलम से आएगा, राइट? सो दिस इज वेरी इंपॉर्टेंट पार्ट. सीक्वेंस भी पूछा जा सकता है कि व्हाट इज द प्रॉपर सीक्वेंस ऑफ दिस ऑल ऑफ दिस सेगमेंट. सो फर्स्ट दैट एक्शन पोटेंशियल कम्स, कैल्शियम गेट्स एंटर, डीएचपीआर एक्टिवेट, ryanodine receptor open, calcium efflux, it goes to the troponin C, it binds with troponin C, remove the tropomyosin, actin myosin coupling. So this is the proper sequence, can be asked in your examination, right? Coming to the next question, a patient developed descending paralysis after consuming improperly preserved canned food. Botulism toxin prevent release of the acetylcholine by blocking. तो क्वेश्चन के अंदर पे प्रिजर्व केन फूड देखो आप मेंशन कर रखा है, एंड साथ ही साथ इट इज ऑलरेडी मेंशनिंग इन द एमसीक्यू दैट देयर इज द बोटुलिनम टॉक्सिन टॉक्सिसिटी. So guys, we know botulinum toxin toxicity mainly happens due to the canned food. And guys, what this botulinum toxin will do? This botulinum toxin is actually block the snare protein. It block the snare protein, and if snare protein is going to be blocked, acetylcholine vesicle cannot be released out, cannot be getting out from the presynaptic area, and no muscle or the no transferring of the signal can be possible from the neuromuscular junction, right? So please pay attention over here. We discuss in the class that this is your presynaptic area, and this is your postsynaptic area. Inside of this presynaptic area there are the bags which is completely filled with the acetylcholine. तो इसके अंदर क्या है बेटा? Acetylcholine. This is we called as vesicle, and this vesicle containing on top a protein we called as snare protein. What we call this? Snare protein. Please pay attention. This is your calcium channels. There are two type of calcium channel, fast calcium channel and the slow calcium channel. So two type of calcium channels are there, and guys, you can see over here, whenever this acetylcholine get out from this presynaptic membrane, guys, this will enter into the synaptic cleft, and then it bind over here with the receptor. So suppose this is the receptor which is situated over here, and this is we called as acetylcholine receptor. Guys, whenever the action potential comes from the upper side like this, the action potential is coming, this will open up this calcium channel, calcium get enters. Once the calcium get enters, it activate the snare protein. This activation of the snare protein lead to vesicle exocytosis. this exocytosis happening, leading it, this acetylcholine will reach into the receptor level. It bind with the receptor, it activate and open the sodium channel over here, and this sodium influx lead to positivity at this postsynaptic area and transferring the signal from this area. So this is how this neuromuscular junction is actually function. So this is your neuromuscular junction, NMJ, very very important. So guys, please pay attention. If this action potential is not coming properly, this could be happen due to the puffer fish poisoning, which contain tetrodotoxin. Number two, this calcium influx which is happening over here, if this fast calcium channel get defected, this condition we called as Lambert-Eaton syndrome. If the snare protein get a damage, guys, this could be happen due to the botulinum toxin. And guys, this is the receptor. If they are getting disturbed, this is possible due to the autoimmune condition, and this condition we called as myasthenia gravis. So these are the different condition which you have to remember, and you should remember all this sequence also, right? So what is happening first, then second, then third, then fourth. Guys, in Lambert-Eaton and in myasthenia, guys, the condition will be same. Muscle will be fatigued, muscle will be paralyzed, like all the condition will be same. Only you have to differentiate this Lambert-Eaton and myasthenia gravis on the basis of the condition. In Lambert-Eaton, when the person is coming to you and this person will tell to you that, doctor, my morning is worst, but evening gets better in compare to morning part. But in myasthenia gravis, morning is better and evening is worse. So this is only the differentiation between Lambert-Eaton syndrome and your myasthenia gravis, right guys? तो अगर क्वेश्चन के अंदर मेंशन होगा कि मॉर्निंग उसको बेकार है और बाय द डे प्रोग्रेस कंडीशन इज गोइंग टू बी इम्प्रूव, what is the condition? Lambert-Eaton syndrome. And if the question is mentioning the morning is fine, but as the day progress, symptom getting worst, so this is the condition of myasthenia gravis, right? So if the botulinum toxin is going to be present at this area, this block the snare protein and no vesicle can get out from this area. So guys, the right answer of this question, botulinum toxin prevents release of acetylcholine by blocking the snare protein, right? Coming to the next MCQ, a 62-year-old chronic smoker present with proximal muscle weakness that improves after repetitive muscle use. Reflex are reduced. Chest CT reveals a small cell lung carcinoma. And what is the most appropriate mechanism cause this? Nicotinic acetylcholine receptor, postsynaptic muscle membrane, presynaptic voltage gated calcium channels, and the ryanodine receptor. Guys, the question is saying number one, muscle weakness is there, right? Muscle weakness is there, and which is improves after repeated muscle use. So just now I told you, morning is worst. As the day progress, person repeatedly using the muscle, condition going to be better. Guys, this is the condition where the Lambert-Eaton syndrome is classically mentioning. So this is classically mentioning the Lambert-Eaton syndrome condition. And in Lambert-Eaton syndrome, this is the presynaptic voltage gated calcium channel condition, right? So there is the fast calcium channel gets defected. So the right answer of this question is presynaptic voltage gated calcium channel, right? Now, coming to the next, a 24-year-old trekker develops headache, nausea, dizziness, confusion, and the insomnia 12 hours after reaching an altitude of 38 meters. What is the most prevalent cause for this condition? Guys, this is the most frequent MCQs which is repeatedly asking in your FMGE examination or in the NEET PG examination. Guys, there is the three condition related with the mountain sickness. acute mountain sickness, high altitude cerebral edema, high altitude pulmonary edema. So guys, you have to be understand all these three conditions. In the previously, I also made a special video on this mountain sickness condition. So you can watch that video also, you can able to understand. And here you have to be identify what is the right answer. The right answer of this question is cerebral vasodilation due to the hypoxia. Always remember, whenever there is a hypoxia in the brain, this can lead to the vasodilation of the vessels. But if the hypoxia in the body, this can lead to the vasoconstriction in the lungs. So this is going to be opposite condition. So in whole body, hypoxia will do the vasodilation, but in the lungs, hypoxia will always do the vasoconstriction. And whenever the vasoconstriction, the pressure is going to be increased, pulmonary hypertension, that can lead to the edema. We call it as high altitude pulmonary edema, HAP, right? So this is the right answer to this question is cerebral vasodilation due to hypoxia. So what are the different type of high altitude sickness? Number one, this is your acute mountain sickness. Number two is high altitude pulmonary edema. And number three is high altitude cerebral edema. बेटा आपको ना इस क्वेश्चन के अंदर पे इनके सिम्टम्स को देखना है. What these symptoms are very important. And guys, these symptoms in acute mountain sickness are nausea, vomiting, dizziness, blocked ears, headache, fatigue, lack of appetite, insomnia, discomfort, and rapid heartbeat. Right? In high altitude cerebral edema, there will be hallucination, loss of consciousness, fever, photophobia, hypertension, confusion, coma, shortness of breath, and inability to walk. In high altitude pulmonary edema, there will be dry cough, nose bleeding, shortness of breath, higher temperature, chest tightness, rapid heart rate, congestion, swelling, and fainting. So guys, these are the symptoms which you have to be remember. आपको याद रखने ही पड़ेंगे, right? So you always will get the idea from these symptoms कि वो acute mountain sickness की बात कर रहा है, high altitude pulmonary edema की बात कर रहा है, या high altitude cerebral edema की बात कर रहा है, right? So you can watch in this MCQ. There is headache, nausea, dizziness, confusion, and the insomnia. Guys, please pay attention. सबसे पहले शुरू होएगा acute mountain sickness, then followed by high altitude cerebral edema, and then followed by high altitude pulmonary edema. So already person was having the acute mountain sickness, headache was there, dizziness is there, insomnia is there, right? But person is also entered into the confusion state as well. So this is going towards the high altitude cerebral edema. तो अगर वो acute mountain sickness के साथ में बाकी की condition भी दे, you can be differentiate whether it is AMS, whether it is HACE, or whether it is HAP, right? So this is the most important part you have to be remember. And guys, the treatment part is also very important. अगर वो आपको AMS के बारे में बोलता है and पूछता है what will be the treatment of choice, then the treatment of choice will be acetazolamide. Acetazolamide. If the question is asking about the HACE, high altitude sickness दे रखा है, लेकिन cerebral edema की condition दे रखी है, and then asking the treatment, then the treatment is dexamethasone or either steroids. And if the question is given for the HAP, high altitude pulmonary edema, then the treatment of choice become nifedipine. Right? So please pay attention. बहुत बारी क्वेश्चन आया हुआ है और बहुत सारे बच्चों ने all the time जैसे ही वो mountain sickness को देखते हैं, they always choose the acetazolamide. No guys, there can be acetazolamide, there can be nifedipine, there can be dexamethasone. So you have to be differentiate between these three conditions. Okay, coming to the next MCQ. A premature baby born at 30 weeks of gestation developed tachypnea, intercostal retractions, nasal flaring, and cyanosis immediately after birth. Chest X-ray shows diffuse ground glass appearance. The neonatologist starts CPAP and administers exogenous surfactant. The primary physiological role of pulmonary surfactant is that increase lung compliance by reducing alveolar surface tension, increase pulmonary capillary hydrostatic pressure, prevent diffusion of the oxygen across alveoli, and increase airway resistance during the expiration. Right answer of this question is A. It increase the lung compliance by reducing the alveolar surface tension. बेटा Compliance means the stretchability. Compliance means the stretchability. This is how the alveoli is going to be stretched. So normally alveoli collapsed. When the air enters into the alveoli, this alveoli is going to be expand like this. And this expanding means this is we call as stretchability. And in another term, we can call it compliance. So compliance को आपको बस ऐसे याद रखना है कि compliance means the stretchability. And guys, whenever the alveoli is collapsed, this alveoli is having a surface. On the surface, it is having a layer of water, and this water layer put the pressure on it. We call it as surface tension. So if the alveoli want to inflate, guys, this surface tension need to be encounter. इसको हटाना पड़ेगा surface tension को. अगर surface tension को नहीं हटाओगे तो alveoli cannot be inflate properly and air can't come inside properly. So this surface tension is counter by the phospholipid element, lipid element by the body, and this lipid element we call as surfactant. Very, very important. So surfactant, it increase the lung compliance by reducing the alveolar surface tension. तो देखिए बेटा, इतने मल्टीपल लाइनर क्वेश्चन के अंदर उसने ऊपर सारी क्लिनिकल हिस्ट्री दी, बट नीचे उसने सिर्फ क्या पूछा, फिजियोलॉजिकल रोल ऑफ पल्मोनरी सर्फेक्टेंट. सो व्हेनेवर यू आर सीइंग एनी मल्टीपल लाइनर in your examination, first read the last line, see the options, and then start reading the full question, right? So you can save the time by this trick. Okay, now please talk about the pulmonary surfactant in a very short way. This is present in the inner lining of the alveoli coated by the surfactant, and this is actually the active agent that decrease the surface tension. Very, very important. And pulmonary surfactant is a thin liquid film of the alveolar lining that decrease surface tension at the gas liquid interference of alveoli. And guys, this is actually made up of lipoprotein rich in phospholipid, and the major surfactant is DPPC. DPPC, dipalmityl phosphatidylcholine, which is also called as lecithin, dipalmityl lecithin, right? And this is your major surfactant. This is your major surfactant. Another surfactant, which is we called as minor surfactant, we called as sphingomyelin. Sphingomyelin. And guys, this sphingomyelin and the lecithin, this gives the idea of fetal lung maturity test, right? So whether the fetal lung are mature or not, this will give us the idea by this surfactant production, right? So you have to remember, surfactant start producing from the 20 to 24th week of intrauterine week. It is going to be appear in amniotic fluid from the 28th week, and this is maximum at the 32 to 34th week, right? If surfactant is not present, this can lead to the hyaline membrane disease or the respiratory distress syndrome, right? So this is all the things you have to remember for surfactant part. Coming to the next MCQ, a 68-year-old diabetic patient undergoes renal function testing. The nephrologist administers an intravenous substance that is freely filtered at the glomerulus, neither secrete nor reabsorb, and not metabolized by the kidney. The clearance of this substance accurately represents the glomerular filtration rate. Which substance was administered? So question is clearly mentioning something enter into the glomerulus, later it secretes from here, later it not reabsorb, and it is not secrete. Means whatever it comes from here, it comes freely and then goes out freely from this area. Guys, this is actually your inulin. This is your inulin. Because the clearance rate of the inulin in exact like the GFR, this is 125 per minute, right? 125 per minute. What is the clearance rate of the creatinine? That is 139. So initially creatinine will be filtered, later the remaining part will be secrete. Para-amino hippuric acid, this is responsible for renal plasma flow, and urea clearance is around 70, right? So please remember this part. Inulin, that is gold standard for the GFR. Creatinine, that is most commonly used clinically. तो अगर वो एग्जाम में पूछ रहा है कि which is the most commonly clinically used for the GFR, then you should choose the creatinine. But asking gold standard, inulin. PAH, that is for renal plasma flow. Cystatin C, this is the new marker for the GFR estimation, and urea, it is influenced by the hydration and the protein intake. Coming to the next, a 39-year-old woman admitted in ICU with ventilatory support on routine morning sample collection, arterial blood gas has the following values. pH is 7.11, PaCO2 is 25 mmHg, and bicarbonate is 11 milliequivalent per liter. What is the most likely acid-base disorder, right? So this is the bread and butter MCQs for all those who studied ABG from me. So guys, what is the right answer for this question? You should get it. You should answer it, right? So you can see the pH is towards the acidic side. So definitely it is acidosis. Now please identify the culprit. Who is culprit? Whether it is CO2 or bicarbonate. Guys, please see the value. CO2 is less, means this is causing alkaline, not acidic. And bicarbonate is also less. What is the property of bicarbonate? Alkaline. So this less means this is causing acidosis. So who's the culprit? Bicarbonate is the culprit. And that's why this is metabolic acidosis with compensatory respiratory alkalosis. So right answer of this MCQ is option number B, metabolic acidosis with compensatory respiratory alkalosis. Please remember this condition. That rule is CO2 property is acidic and bicarbonate property is base. So this is the table we discussed in the class also. So you just keep this table in your mind before entering into the examination hall, and you will never do the mistakes while you are solving all the ABG's MCQs. Okay. Coming to the next, a 25-year-old healthy male undergoes spinal anesthesia for inguinal hernia repair. Shortly after induction, he develops sudden severe bradycardia, hypotension, and diaphoresis. The anesthesiologist explains that decreased venous return has activated ventricular mechanoreceptor, producing increased vagal activity. The reflex responsible is brain bridge reflex, Cushing reflex, Basal-Gerris reflex, and the baroreceptor reflex. The right answer of this question is Basal-Gerris reflex, because there is marked bradycardia, hypotension, right? Bradycardia and hypotension, and bradycardia and hypotension, this is the condition of Basal-Gerris reflex, because brain bridge reflex, this is suppose your heart. Please remember guys, this is suppose your heart. So if this area is producing any reflex, this is we called as brain bridge reflex, and this always do the increase the heart rate and increase the BP. So there will be hypertension and hypertension, and there will be the tachycardia, right? Tachycardia. If this area left ventricle is showing any reflex, this always do the bradycardia and the hypertension, and this is actually we called as Basal-Gerris reflex. Cushing reflex, this is related with intracranial pressure. If pressure will be increased, this is related to the Cushing reflex. And baroreceptor, this is something different, leading to the blood pressure stimulation part, right? So this is how the different reflex you have to be remember. So guys, please pay attention. Brain bridge reflex, this is activated via increase the venous return. Cushing reflex via increase the ICP. Basal-Gerris reflex due to the MI or decrease the preload. And CNS ischemic response, this is due to the severe cerebral blood flow, right? What is the most common cardiovascular response in brain bridge reflex? Please remember, brain bridge, जब भी ब्रिज बनता है तो आप तेज चलते हैं धीरे चलते हैं? जब ब्रिज बन गया नदी के ऊपर तो डेफिनेटली आप तेज चलेंगे. तो बेन ब्रिज बन गया तो आप कैसे चलेंगे? तेज. तो बेन ब्रिज रिफ्लेक्स विल ऑलवेज डू द टेकिकार्डिया, राइट? Basal-Gerris reflex, this will do the paradoxical bradycardia and hypotension, and the Cushing reflex will do irregular respiration, bradycardia, and hypertension. We call it as Cushing triad, and the CNS ischemic response will do the severe hypertension, right? Severe hypertension. So this is the table you have to be remember before your examination, and you will never do the mistake between the brain bridge reflex, Cushing reflex and the Basal-Gerris reflex. तो देखो बेटा, ब्रिज को तो आप याद रख सकते हो, ब्रिज बन गया आप कैसे चलोगे? तेज चलोगे. सो बेन ब्रिज रिफ्लेक्स, टेकिकार्डिया जनरेटिंग फ्रॉम द राइट एट्रिया. Basal-Gerris reflex, slow down the heart rate, उसका opposite, और that is from the left ventricular condition, right? Left ventricular condition. Coming to the next, a 72-year-old diabetic patient develops sudden violent flinging movements of his left upper and lower limb after suffering a small stroke. Neurological examination is otherwise normal. The lesion is most likely located. Guys, this is mentioning that this upper part is involuntary movement is there, and same side lower part is involuntary movement is there. Means half side of the portion of the body is affected, and this condition we called as hemibellismus. Hemibellismus, which is responsible for lesion at subthalamic nuclei, and subthalamic nuclei contain which neurotransmitter? Glutamate. So right answer of this question is person is having flinging movement on the left side. So means brain is always located or controlled from the opposite side. So right side of subthalamic nucleus will be affected, right? So this is the basal ganglia chart. You have to remember this basal ganglia chart, that Parkinson disease. This is the lesion in substantia nigra pars compacta, and the neurotransmitter involved in Parkinson disease is dopamine. Clinical feature will be resting tremor, rigidity, bradykinesia, and postural instability. Huntington disease, the lesion at caudate and the putamen nucleus. Neurotransmitter, that is GABA and the acetylcholine, which will be involved, and clinical feature there will be the chorea, dementia, and psychiatric symptom. In hemibellismus, there will be the site of lesion at subthalamic nuclei, neurotransmitter involved, that is glutamate, and there will be the violent flinging movements of contralateral limbs. In Wilson disease, there will be the lesion in putamen most commonly. This will affect the dopamine pathway, and there will be the tremor, dystonia, dysarthria, psychiatric symptoms will be there. And in drug-induced Parkinsonism, there will be lesion in nigrostriatal pathway, neurotransmitter which is going to be affected, again the dopamine, and there will be the Parkinsonian features after the antipsychotic drug will be occur. So this is how, with this table, you can easily differentiate between all of these conditions. And guys, one question all the time is asked from all of these diseases, right? So with this table, you will never do the mistakes. I hope so. Coming to the next, a 28-year-old man is brought to the emergency department after sustaining a knife injury to the right side of the thoracic spinal cord at T8 level. Neurological examination reveals weakness of the right lower limb. Sensory examination demonstrates loss of vibration position sense on the right side and loss of pain and temperature sensation on the left side below the lesion. The most likely diagnosis is, guys, please pay attention. Person is having injury. Suppose if this is the person, person is having injury at this level, right? Suppose at this level, this is T8 level, right? Now what the question is saying? Question is saying the neurological examination reveals there is a weakness on right lower limb. Sensory examination demonstrate loss of vibration and position sense, means the proprioception on the right side. And where is the lesion? Lesion is also right side. Suppose this is right side and this is left side. So lesion on this side, and the loss of vibration and the proprioception is also from this side. So this side vibration plus proprioception is lost, right? And the pain and temperature sensation is lost on the left side. So for this side, pain and temperature is lost. Guys, why this condition is occurring? Because we know when the pain and temperature fibers goes upside, they decussate at the level of spinal cord and then they goes upside. But when this dorsal column pathway, they actually decussate at the level of medulla and then they goes to the upside. So you can see on this side, the half portion of the spinal cord if damaged, this condition we call as Brown-Sequard syndrome. And in Brown-Sequard syndrome, please remember, dorsal column is always lost on the same side, ipsilateral side, and the spinothalamic pathway, which is anterolateral pathway, the spinothalamic always lost on the contralateral side, right? So remember the Mallika kahani जो अपन ने पढ़ी थी बेटा क्लास के अंदर पे. So this is the condition which is mentioning for the Brown-Sequard syndrome. So right answer of this question is C. There are the different type of cord syndrome: anterior cord syndrome, central cord syndrome, Brown-Sequard, and the posterior cord syndrome. So what is the meaning of this part? Central cord syndrome means if this is completely over spinal cord, if this damage from the central part only, then we call as central cord syndrome. If anterior part is lost, then anterior cord syndrome. If half portion of this entire spinal cord is gone, guys, this is we called as Brown-Sequard syndrome. And if only the posterior part is gone, we call as posterior cord syndrome. So what is the exam point you have to remember? In anterior cord syndrome, there will be motor, pain and temperature will be lost, but dorsal column will be spared. Dorsal column will be spared. So you can remember dorsal means posterior, but the injury on anterior. So dorsal column will be spared in anterior cord syndrome. Central cord, upper limb weakness will be more than the lower limb weakness. Brown-Sequard syndrome, ipsilateral motor and proprioception loss and contralateral pain loss. And posterior cord syndrome, loss of dorsal column, means the vibration and position sense with the sensory ataxia. So this is you have to remember. You can easily differentiate between all of this cord syndrome. Next question is a construction worker uses a pneumatic drill for several hours daily. The vibration generated by the machine is primarily detected by which receptor? Merkel disc, Pacinian corpuscle, Meissner corpuscle, and the Ruffini endings. Guys, pneumatic drill, जो drill machine होती है, and this always give you the lot of vibration in your hand. So question is simply asking कि आपको जो vibration है ये कौन से receptor से basically feel होते हैं? And the right answer of this question is C, Meissner corpuscle, right? So please pay attention, guys. Please pay attention. Sorry, not Meissner corpuscle. This is B, Pacinian corpuscle. Guys, please pay attention. The Meissner corpuscle, this is for the fine touch flutter movements. Fine touch and the flutter movements. Then the Merkel disc, this is for the touch and the pressure. The Pacinian corpuscle, this is for the vibration, for the deep vibration. Ruffini is for skin stretching, and free nerve ending for pain and temperature. Pain and temperature. So this is very important table, guys. You have to remember. They can give you in a complex way, like what is the true statement regarding the Meissner corpuscle or Merkel disc or Pacinian or the Ruffini, anything in a different manner they can ask you from this topic, right? So the vibration is generally detected by the Pacinian corpuscle. So right answer of this question is B, Pacinian corpuscle, right? Coming to the next, a healthy 21-year-old student is sitting comfortably in a quiet room with eye closed but remains awake and relaxed. The predominant EEG rhythm is recorded. So question is quite easy. Eye closed but awake. This is your alpha wave. So option B. Please remember, in EEG there are total 5 waves. Number 1, when right now you are awake and open eyes. Guys, when your eyes are open and you are awake, if right now if I'll put an electrode over here, guys, the wave which I will see on the EEG, this is called as a beta wave. When you close your eyes, suppose you are thinking something and you just close your eyes, आपने आंखें बंद कर ली और आप कुछ सोच रहे हैं. During this time you are awake but your eyes is closed. So slightly your brain activity will be dropped down. During this time the wave I will see, this we called as a alpha wave. When you start sleeping, initially you sleep with the light sleep. So in light sleep, you will always have the theta wave. And when you will go into the deep sleep, you will have the delta wave. And guys, when you will be highly focused, means thinking a lot, your brain is moving like this, you will see the high frequency wave, that is your gamma wave. And during the REM sleep, rapid eye movement sleep, you will always have the same like wave which you are actually having during the awake condition. So in REM condition, you will have the beta like wave, right? Beta like wave. So this is how, once again, when your eyes are open and you are awake, this time beta wave. When your eyes are closed but you are awake, that is alpha wave. When you are going into the light sleep, your theta wave. And when you are in deep sleep, guys, this is your delta wave. Highly focused, gamma wave. So this is how we can easily remember the gamma, beta, alpha, theta and the delta wave, right? The next question is, a patient develops persistent hyperthermia following surgical removal of a hypothalamic tumor. The neurosurgeon suspect damage to the center responsible for the heat dissipation. Which hypothalamic area has most likely been injured? So guys, this could be posterior hypothalamus or lateral hypothalamus or anterior hypothalamus or arcuate nucleus. So what is the right answer? Guys, I told you the various hypothalamic center, which is very, very important. And what is the question is saying? Question is saying that person gone for the tumor surgical resection and the person is having persistent hyperthermia. Persistent hyperthermia means high temperature is there. Person is not able to control this part. And guys, person can control the hyperthermia by which portion of the thalamus? By the anterior hypothalamus, right? Anterior hypothalamus. देखिए गर्मी लगती है तो पसीना कहाँ से पहुंचते हैं? एंटीरियर से पहुंचते हैं ना बेटा. तो this is how you can easily remember. Hyperthermia, गर्मी लगी, anteriorly अपन ने पसीना पहुंचा. तो for गर्मी, for hyperthermia, the control center on the anterior part of the hypothalamus. सर्दी अपने को कहाँ से लगती है? सामने तो अपन कपड़े ओढ़ लेते हैं, लेकिन पीछे की तरफ क्या होता है बेटा? अपना पोर्शन खुला रह जाता है. एंड ड्यूरिंग दैट टाइम वी ऑलवेज फील द कोल्ड. तो हाइपोथर्मिया इज कंट्रोल्ड बाय पोस्टीरियर हाइपोथैलेमस, राइट? पोस्टीरियर हाइपोथैलेमस. सो दिस इज द इजीएस्ट वे टू रिमेंबर. इससे आई होप कि आपको याद रह जाएगा, राइट? सो दीज आर द डिफरेंट हाइपोथैलेमिक सेंटर. Anterior hypothalamus, this is the heat loss center. Lesion effect or disease will do the hyperthermia. Posterior hypothalamus, heat conservation center. This lesion will do the hypothermia. Ventromedial nucleus, this is the satiety center, and if this is going to be loose, person start eating more, so hyperphagia and obesity. Lateral hypothalamic area, this is for the hunger or feeding center. If the lesion is going to be effect, the lesion will be there will be the anorexia and the weight loss. Supraoptic nucleus, this is responsible for ADS synthesis, and if this is lost, central diabetes insipidus can be occur. Paraventricular nucleus, this is the oxytocin responsible, impaired milk ejection can be occur. Then the suprachiasmatic nucleus, this is for the biological clock, circadian rhythm, and if this is going to be lost, sleep disturbance will be there. Arcuate nucleus, this is the appetite regulation and GnRS secretions. So if the lesion will be there, this lead to obesity and reproductive dysfunction. Preoptic area, this is for again GnRS secretion and thermoregulation, and if this is going to be lost, hypogonadism and infertility can be occur. And mammillary bodies, this is for the memory and limbic function, and if this is going to be affect, memory loss and the Wernicke-Korsakoff syndrome can be occur. So these are the different hypothalamic nucleus which have to be remembered. One mnemonic I told you during the classes, that is SOAP. Supraoptic nucleus for the ADH, and paraventricular nucleus for the oxytocin. This is how you can easily remember, right? Coming to the next, a 65-year-old patient suffers a lateral medullary infarction. Soon after this event, he develops irregular breathing with episode of apnea requiring ventilatory support. Which structure acts as the primary inspiratory center and is most likely affected? So guys, option A is pneumotaxic center, apneustic center, dorsal respiratory group, and the cerebral cortex. So the infarction is happen at the medulla. The first clue is this is at the medulla, and we know if suppose this is the pons, this is the medulla, and this is the spinal cord, we know the three center is present. The three center is present into the medulla. This is your DRG, dorsal respiratory group. This is the VRG, ventral respiratory group, and this is your pre-Bottginger complex. Which is the pacemaker of the respiration. This is for normal inspiration. This is for forceful expiration, and two center is present into the pons. Which one? This is the pneumotaxic center, and this is your apneustic center. So this is your pons, and this is your medulla. So question is already mentioning that person is having the medullary infarct, right? And in medullary infarct, he is having which area? There he develops irregular breathing and episode of apnea requiring the ventilatory support. Which structure act as a primary inspiratory center? So just now I told you, primary inspiration is done by the DRG, right? DRG. So this is how you can remember. This is the primary inspiration center. This is the pacemaker of respiration. This is for forceful respiration. This is increased depth of inspiration. And this is for limit the inspiration. So this is how we are having total five respiratory center. Out of that, 3 is present at the medulla and 2 is present at the pons, right? So person is having infarct at the medulla and the primary inspiratory center is asked. Right answer of this question is C, that is dorsal respiratory group. So this is the table which you have to be remember. The dorsal respiratory group, this is at the dorsomedial medulla. The normal function is main inspiratory center and abnormality can lead to irregular breathing, respiratory failure. VRG situated into the ventrolateral medulla. This is for the forced inspiration. Pre-Borzinger, pneumotaxic center, apneustic center. Then the central chemoreceptor and peripheral chemoreceptor. Central chemoreceptor again situated into the medulla, but peripheral chemoreceptor situated into the carotid and aortic bodies, right? And this respond to the decreased level of the oxygen, right? Decreased level of the oxygen. Coming to the next question, is 70-year-old man present with recurrent syncopal attack and dizziness. ECG reveals regular P waves and regular QRS complexes, but there is no relationship between them. The atrial rate is 80 and ventricular rate is 35. What is the most likely diagnosis? Guys, you can easily see there is no relationship between QRS and the P wave. And guys, this is suggestive of third degree AV block, which is also called as complete heart block. Complete heart block. And another name, complete atrioventricular dissociation. So either you can call it third degree heart block, either you can call it complete heart block, either you can call it complete atrioventricular dissociation, right? So the clue is in the MCQ is that there is no relationship between them. So what is happening in the first degree? First degree, P is normal, QRS is normal, simply PR is constantly prolonged. In second degree, Mobitz type 1, there is progressively increasing of the PR. And then there will be the drop bit, Mobitz type 1. In Mobitz type 2, PR is normal and constant, but there is a regular drop bit, that is Mobitz type 2. And the third degree heart block, that is there is no relationship between P and QRS. So guys, in the class, I told you with the story of the Bhabiji, so you can remember with that part, this is your heart block. So heart block, this is the table, PR, dropped QRS and the PQRS relationship between all of this condition, right? Now, coming to the next, a 58-year-old man present to the emergency department with severe retrosternal chest pain radiating to the left arm for the last 2 hours. ECG image shown below, troponin I is elevated, which is the correct pair regarding given ECG. So clear-cut message, this is the condition for MI. Now we know MI can be anterior wall MI, septal wall MI, lateral wall MI, inferior wall MI and the posterior wall MI. So you have to see the leads into this condition. So guys, I just told you that in the MI there is always ST elevation. So please identify where is the ST elevation. So first check the rhythm strip. The rhythm strip is showing, yes, there is the ST elevation. You can see over here. So this is this cat, billi बैठी है, ये बिल्ली जो बैठी है, this is actually indication for the MI. Now in which lead actually this cat you can see over here, you can see in lead 2, you are seeing in lead 3 and you are seeing in lead AVF. And guys, 2, 3 and AVF. This is suggestive of inferior wall MI. So remember guys, I told you that you are having, this is V1, V2, V3, V4, V5, V6, and for inferiorly side there will be 2, 3 AVF, right? 2, 3 AVF. So remember the diagram which I used to explain during the classes. This is right side, this is left side. So what you can do, first you will place the one lead over here, another lead over here, and another lead over here. This is we called as AVR, this is AVL, and this is AVF for foot. Now you have to connect all them together like this, and like this. This is we called as lead 1, this is we called as lead 2, and this is we called as lead 3. So you can see which 3 leads are going downside. There is lead 2, lead 3, and lead AVFs. They are going towards downside. So if inferior wall is there is always changes in lead 2, lead 3, and lead AVF. So guys, you can see there is lead 2, lead 3, and lead AVF is showing ST elevation, and this is suggestive of inferior wall MI. This is suggestive of inferior wall MI. Please pay attention guys, please pay attention that if there is the septal wall MI, then this is the V1, V2 coming to the middle, and septum is also coming to the middle. So whenever there is a ST elevation in V1, V2, septal wall MI. This is V3, V4. So whenever the V3, V4 is having the elevation, this is coming the anterior side. You can say this is the anterior wall MI. This is V5 and V6. Guys, this chest lead is coming to the lateral position. So whenever there is elevation in V5, V6, this is lateral wall MI. And on the back side, there will be the V7, V8, and V9. If there is the elevation, this is suggestive of posterior wall MI. So V1, V2, septal wall, V3, V4, anterior wall, V5, V6, lateral wall, V7, V8, and V9, posterior wall, and 2, 3, and AVF, inferior wall MI. Right guys? There can be V1, V2, V3, V4. This could be anteroseptal wall MI, and V3, V4, V5, V6, anterolateral wall MI. So this is how you can remember, and this is very easy bread and butter MCQs guys. You can easily remember with this trick. So right answer of this question is C. Inferior wall MI, there is actually the affected of right coronary artery. Right coronary artery. So you can remember over here with this table that in ischemia there is always the ST depression. In MI there is always ST elevation. In hyperkalemia there is tall tentative wave, and in heart block there is PR abnormality. You have to check, right? Now please pay attention. In septal wall, the ECG leads is involved V1, V2, anterior wall V3, V4, lateral wall V5, V6. V5, V6, and inferior wall 2, 3 AVF, and posterior wall V7, V8, V9. Please also remember the vessels which is actually leading to this condition. So in septal wall and in anterior wall, this is LAD. Which one? LAD, left anterior descending artery. Lateral, that is left circumflex artery. Inferior, that is right coronary artery. And posterior, that is posterior descending artery, right? Posterior descending artery. So this is how you can easily remember and easily solve this MI MCQs whenever they ask in your examination, right guys? So this is all from this high yield topics for this upcoming FMGE examination. Thank you very much for watching this video. Wish you all the best. In this last time guys, the one thing you have to remember, no need to be panic. You have worked hard a lot from past several days, from past several months. आप लोगों ने बहुत सारे GT दिए हैं बेटा, बहुत सारे एग्जाम करें, बहुत सारे मॉक पेपर आप लोगों ने दिए हैं. So please believe in yourself and go with same dedication while you are solving the mock, while you are solving the GTs, right? So if you will start thinking कि हमको तो एक दोबारा से एक नया GT या मॉक देना है on the day of examination, you won't be panic. And अगर आप panic नहीं होंगे guys, you won't do the silly mistakes, and silly mistakes avoiding condition will definitely increase your marks, and you will definitely will come with your flying colors. So wish you all the best to all my lovely students. पेपर फोड़ के आना है, दिखा के आना है. Thank you very much.